my name is Cassidy, and for my test evaluation project, I did the Clark-Beck Obsessive-Compulsive Inventory. To start with a little general information about the Clark-Beck Obsessive-Compulsive Inventory, or the CBOCI for short, it was created by authors David Clark and Aaron Beck and was published by Pearson in 2002. The cost of the test can vary anywhere between $80 to $186 depending on which kit is purchased, and below I just provided a little image of what each kit includes and what that kit would cost, and to the right of that image I provided a couple pictures that show what that manual would look like, as well as what that test report form might look like. As far as user qualification and classification of the test goes, it is a Level B qualification, which means the administrator should be a trained professional, and in order to access any Level B test, the user must be at the graduate level or have comparable training in psychological testing and measurement. Going into the nature and purpose of the CBOCI, it's a brief self-report symptom screener that's used to identify obsessive and compulsive symptoms. It has 25 items that are graded from 0 to 3, and they both measure the frequency and severity of OCD symptoms. The test itself has two correlated subscales, the first being obsessions, which are the first 14 items, and the next being compulsions, which are the next 11 items, and they measure feelings of contamination, harm, moral and religious and sexual thoughts, as well as mental patterns such as feeling out of control or feeling overly responsible, doubtful, or distracted. The appropriate population of the test was stated to be ages 17 and older, and that's because different age groups, particularly young children, they might exhibit different symptom profiles that require different assessment tools in order to properly diagnose their symptoms from their behaviors. Pearson assessment stated that the CBOCI was developed to provide an efficient yet comprehensive and precise self-report screening for OCD as well as OCD symptoms. For the instrument's evidence of reliability, I decided to look at the CBOCI's coefficient of internal consistency. Clark et al. Reported that the CBOCI demonstrated a strong internal consistency for both the obsessions and the compulsion subscales. The Cronbach A's values indicated that the items within each subscale consistently measured the same construct. For the 15-item obsession subscale, it had an alpha value of 0.85 in the OCD sample and an alpha value of 0.89 for the total sample. For the 12-item compulsion subscale, it had an alpha value of 0.84 for the OCD sample and an alpha value of 0.89 for the total sample. For reference, an alpha value of 0.9 and above suggests excellent internal consistency for an instrument. Moving into the evidence of validity, I decided to look at the CBOCI's concurrent validity, and Clark et al. Reported that the CBOCI was validated by comparing it with 4 other well-established OCD measures. In summary, what they found was the CBOCI's total score and subscale scores were significantly correlated with well-established OCD measures, especially with the Yale-Brown Obsessive-Compulsive Scale and the Maudsley Obsessive-Compulsive Inventory, which showed a strong concurrent validity. OCD patients scored significantly higher on the CBOCI than the non-clinical groups, and the authors concluded that the CBOCI demonstrated good convergent and discriminant validity, meaning that it effectively measures the same underlying constructs as other OCD assessments, while still distinguishing OCD from other disorders. For the practical evaluation of the instrument, I've already stated that the CBOCI is a self-report measure, but it can be completed on paper or done digitally, and the assessment typically takes around 10 to 20 minutes to complete, but it's primarily used to screen for the severity of OCD symptoms rather than to provide a formal diagnosis of OCD. To the right, I've provided an image that breaks down the CBOCI items, and I just thought it would be neat to visually see what each of the subscales are measuring within the test. Some benefits of the test is that it reflects recent advances in theory and research on the key cognitive and behavioral processes of OCD, and it's consistent with the concurrent diagnostic criteria for OCD according to the DSM-5. The limitations, however, is since the test is a self-report measure, the results could be biased and it shouldn't be used for a diagnosis without a proper follow-up interview. Looking a little further into the practical evaluation, I wanted to provide an example of what one of the record forms might look like. However, since these are classified kits, I wasn't able to access the full report, but I'm going to try to break it down as simply as possible. So subtotal 1 is responsible for measuring the obsession subscale, which again is the first 14 questions on the item inventory, and it measures the frequency and intensity of obsessive thoughts. Subscale 2 is going to be the compulsion subscale, which is the last 11 questions on the inventory, and it measures the frequency and intensity of compulsive behaviors. The total score is going to be the sum of both scores in the subscales, and it's used for the initial screening that provides the diagnostic impressions of someone's obsessive and compulsive symptoms. So for example, you keep hearing me say the scales are graded from 0 to 3, and what that means is a score of 0 would indicate the absence of OCD symptoms, while a score of 3 would signify a high level of difficulty dealing with those symptoms. And the scores are then summed for the two subscales, and the total scale is calculated to identify the severity of the symptoms with the specific score ranges that correspond to minimal, mild, moderate, and severe clinical symptom levels. So, for example, the obsession subscale has a maximum possible score of 42. So, a score range from 0 to 9 would indicate minimal severity and non-clinical symptoms. A score of 10 to 28 range would indicate mild to moderately clinical severe symptoms, and a scoring range of 29 to 42 would indicate severely clinical level symptoms of OCD. For the compulsion subscale, it has a maximum possible score of 33, and a scoring range between 0 and 9 would indicate minimal to non-clinical symptoms again, and a scoring range of 10 to 25 would indicate mild to moderate clinical symptoms. And finally, the 26 to 33 range would indicate severe clinical symptom levels. The total score has a maximum possible score of 75, so scoring ranges from 0 to 20 would indicate minimal non-clinical symptoms, 21 to 52 indicating mild to moderate clinical symptoms, and a range of 53 to 75 indicating severe clinical symptoms of OCD. In terms of using this instrument in my own career, I would use it to screen for OCD symptoms during an intake or to monitor a client's progress over time in therapy. However, I would probably still pair it with a structured interview before confirming a diagnosis and creating a treatment plan, since it helps capture the changes in both the client's thoughts and their behaviors over time. And because it is a self-reported measure, answers might change or develop during that time. For my journal article summary, I decided to look at a research article called When Good People Have Bad Thoughts, where the authors Michelle Hale and David Clark looked at religiosity and the emotional regulation of guilt-intrusive thoughts. The title was initially what drew me to this study, but after reading deeper into it, I found it to be a super interesting research study that also happened to use the CBOCI for one of their forms of measurement. Their overall purpose of the study was to examine whether general guilt explains why highly religious individuals might experience stronger, more obsessive thoughts, and their hypothesis predicted that highly religious participants would show a greater overall guilt and guilt-related negative thinking, as well as having higher levels of obsessionality, which are the CBOCI scores, and they expected that both guilt and religiosity would significantly predict obsessionality. So what the authors did for this study is they gathered 164 introductory level psychology students from the University of New Brunswick who were willing to participate, and in return, the students earned course credit. The authors designed a cross-sectional study and wanted to compare high versus low religious groups, and did this based on the importance of religion ratings from the initial questionnaire that participants answered in the very beginning in order to get a baseline of how religious each participant stated to be. For their measures, they used the CBO-CI as well as the revised Obsessional Intrusions Inventory, which measured obsessionality, the guilt inventory and other guilt measures, the situational guilt inventory and mood, guilt, and cognitions inventory, which was developed for the study, as well as additional scales for scrumpulsity, mood, and stress. Their analysis was from group comparisons and regression analysis that were used to identify which factors accurately predicted obsessionality. Looking a little deeper into the results and the conclusions of the study, the authors found that highly religious participants did score higher on the CBO-CI obsession and compulsive subscales, and participants did show greater obsessive and compulsive thinking, as well as having higher and stronger religious obsessions, including the fear of sin and the fear of God. However, there were no significant group differences in anxiety, depression, or stress levels. Their regression analysis showed that general guilt measured by the guilt inventory and the importance of religion were the strongest predictors of the CBO-CI scores. And they also found that guilt about intrusive thoughts did not significantly predict obsessionality, which suggests that broader feelings of guilt may explain why we see higher obsessive symptoms in highly religious individuals. In terms of my own opinion and application of the study shows that guilt and religious beliefs can strongly influence obsessive symptoms, and high CBO-CI scores in religious clients might just reflect moral or guilt-based worries and not just OCD symptoms. So therefore, if I was a psychologist, I would still use the CBO-CI, but I would also try to explore my clients' beliefs and their sense of guilt to better understand their symptoms and religious standings in comparison to OCD and OCD symptoms. Because I really liked this study and found it to be really relative and informative for me, in the next few slides I have a more elaborate version of this breakdown that I provided if you want to pause and read for yourself to get a deeper understanding of their research. I personally enjoyed this research study, but if you're not interested and for the sake of time in my video, feel free to skip to the end. This is the next slide that includes the results and conclusions from the study, as well as my own opinion in the more elaborated version. So feel free to pause and read if you're interested. And finally is just my references slide, and I want to thank you for taking the time and attention for listening to my presentation. Thank you.